Imagine an advanced machine that can temporarily take over the function of heart and lung, giving a patient body to change and recover from the severe illness. This is not scientific fiction. It's a real medical device called ECMO. Greetings, ladies and gentlemen. This video is a part of artificial organ class presentation. Before we continue, I apologize for any mistake and welcome your question clarification afterward. Thank you for your understanding. And today I'm going to review you about the basic concept of medical device called ECMO. It stands for extracorporeal membrane oxygenation. In the overview, this picture below is shown ECMO station. And before we go into a detail, let's talk about the outline. This video is going to talk about what is ECMO, why ECMO, the brief history of ECMO, major components, and the type of ECMO configuration. End up with the conclusion. If you are ready, let's start. The ECMO is a life-saving technique used in critical care where blood is pumped outside of the body to heart-lung machine that remove carbon dioxide, add on oxygen, and then return it to the body. This allows the heart and lung to rest when they can function adequately on their own. The reason of using ECMO is for support the treatment in case of severe respiratory or cardiac failure with high risk of death. The concept of ECMO uses is not the treatment. That is not kill the patient, but it is life support system for extend the time for the severe patient to recover themselves from their disorder. And next, we're going to move to the historical milestone of the ECMO creation. Our journey begins in late 19th century and progressed to the major breakthrough that have defined this life-saving technology, and we have 13 checkpoints to cover. The first one, the early challenge of oxygenated blood in 1882, is marked as the initial attempt to oxygenate blood outside the body. These early experiments were hindered by the complications such as blood clot, which pose significant risk to the viability of transfusing the treat blood back into the patient. This period revealed an extended understanding of blood handling and oxygenating in medical science at that time. Second, introduction of heparin. In 1916, the advent of heparin revolution in medical practice by providing a reliable means to prevent blood clotting. And anticoagulation, heparin became the cornerstone in medical and surgical application, particularly in the intervention involve blood manipulation outside the body, is setting stage for the more complex procedures. And next is the pioneer work in Russia. In 1929, the Russian scientists achieved a significant feat by performing the first extracorporeal perfusion in the dog. This experiment laid the foundation principle for the circulation of oxygenated blood outside the organism, thereby testing the limitation and possibility of support life system. Next, the advance in the oxygenator technology. The decade of 1950 was marked by the rapid technology invention, notably the development of the rotating disc and the glass cover device in oxygenator. This device represents a leap forward in enhancing the efficiency of the gas exchange during the extracorporeal circulation. And we move up to the 1953, the dawn of the cardiopulmonary bypass, witnessed the first successful use of cardiopulmonary bypass in surgery. A success in medicine is also for complex cardiac surgery that were previously unmakeable. This technology provides a temporary substitute for the heart and lung during surgery, ensure oxygenate and circulation via the operation. And next, in 1957, the membrane oxygenator is developed as the first one, which continues to be used in the various forms to this day. Is marked as significant enhancement over previous model. This technology is used the semi-permeable membrane to oxygenate blood and remove carbon dioxide, closely mimic with the natural lung function. And in 1971, the ECMO project milestone is achieved by supporting 24-year-old car accident victim for 72 hours, which lead to the survival against the odds. This marked at the beginning of ECMO as a critical life-saving procedure intensive care unit. And in 1975, the advance in ECMO is used for the baby suffering from the meconium aspiratory syndrome, demonstrate the utility in the treating pediatric and neonatal patients, thus broaden the scope of this application of the ECMO. And in 1978, the innovation in carbon dioxide removal, the first description in 1978 of selective removing the carbon dioxide from the blood via using the ECMO procedures, and it managed the acid-base balance in critical ill patient and enhanced the modality of therapeutic potential. In 1979, a randomized control trial which highlight the challenge of ECMO treatment is show only 10% of success rate in adult patients. This underscore where the complexity of the limitation is ECMO is defined and is ready for the further development. And in 1989, the establishment of ELSO, the founding of Extracorporeal Life Support Organization, or ELSO in 1989, was critical step forward to the standard ECMO practice and enhance patient outcome through global collaboration, data collection, and sharing the best practice into the community. In 2009, the outbreak of H1N1 influenza virus, also known as the swine flu, is marked a critical period for the utilization of ECMO technology. As the pandemic unfolds, ECMO centers across the globe encounter a significant increase in the case involving severe respiratory failure. This situation provides a unique and significant dataset for evaluating ECMO. The clinical success under the pandemic, the surge in H1N1 case, necessitate the widespread use of ECMO, affirming its capability for supporting life in acute viral respiratory condition and thus further establish its role to manage global health emergency. And in the same year, a landmark for study in ECMO effectiveness, one of the most pivotal moments in history of ECMO was the CESAR study. It stands for the conventional ventilatory support versus the extracorporeal membrane oxygenation for severe adult respiratory failure. This study was meticulously designed to evaluate the effectiveness and cost efficiency of the ECMO compared to conventional ventilator. For the patients suffering from severe adult respiratory failure, the trial findings were compelled, showing that 63% patients in ECMO group survived without severe disability, compared to only 47% of the group receiving the conventional treatment. This result significantly boosts the argument of ECMO as is a superior treatment modality for the severe respiratory failure, particularly when administered in the specialized center equipped with the necessary expertise and resource. As we review the historical journey and empirical evidence, such as the provided by the CESAR trial, it's become evident that ECMO is represent not only the medical device, but a paradigm shift critical care. This technology has proved its value repeat by saving lives during the critical health crisis and improve outcome of severe respiratory condition. Outlook. Look ahead, the continued evolution of ECMO technology promises even greater advance with ongoing research focused on enhancing its efficiency, accessibility, and patient compatibility. As we embrace this technology, ECMO stands poised to play the even more crucial role in shaping the future respiratory care and critical medicine globally. Okay, let's move to the system overview. Let's drill down into the component of the extracorporeal membrane oxygenation or the ECMO system. We begin with the basic diagram to ensure clarity on how ECMO functions, focusing on its key components and their role. The first one is the cannula, which are the pivotal in the operational of the ECMO system. The cannula are special tubes used to transmit and receive the blood from the patient. They are very insight based on the operational area, with venous cannula being longer to accommodate with the distance they must cover, and arterial cannula being shorter, and each type is robustly reinforced to prevent a structural failure. And the blood pump, its primary function is to draw the blood from the patient and direct it toward oxygenator, which we will discuss in next. In ECMO system, there are primarily two main pumps. One is the roller and second is the centrifugal pump. The roller pump is designed to prevent the cavitation and effectively remove the air from the bloodstream, operating in an afterload independent manner. On the other hand, the centrifugal pump, which commonly used in ECMO setup, require pieces for adjustment operate to create centrifugal force to move the blood, benefit from being both preload and afterload dependent. And next, we will examine the oxygenator, which is the core component where gas exchange occur. The oxygenator uses a hollow fiber membrane technology. It acts like the alveolar in human lung, where oxygen can go and flow outside the fiber while the blood is full inside. This setup facilitates the efficient exchange of oxygen and carbon dioxide, mimic like the natural respiratory process. Moreover, the oxygenator is worked along with a heat exchanger, which play a crucial role in regulating the temperature of blood before it returns into the body of the patient. This component ensures that the blood is maintained at traditional physiological temperature, helping minimize the thermal state on the patient organ and the tissue. And the study is revealed that the ECMO system integrates with the heat exchanger with the membrane oxygenator, ensuring that the blood is not only oxygenated but also brought the correct temperature, simultaneously making the system more efficient and reduce the risk of temperature-related complications like the induced hypothermia and thermal swing during the therapy. And next, we will go to the blender. It is the crucial component for control the mimics of the gas delivery to the patient. The blender allows the precise adjustment of the oxygen and carbon dioxide. And lastly, the console is served as the control center for managing the circulation and oxygenation of blood outside the patient body. The console ensures that the system is ready for operation and can safely support the patient is working along with the professional and staff control. The console is not only used in the general management of ECMO system, but also used in the specific requirement case that expert can adjust it to operate depend on the patient and the resource limitation. And this is all about the major component of ECMO. And this is the visualization how each component is attached together to make the ECMO system complete. After we care about the ECMO function, in this section, we'll dive into the technical aspect of how ECMO cannula are connected to the patient, focusing on how two primary ECMO configuration, the venous to venous and the veno to arterial. Each setup is designed to meet specific clinical requirements based on the patient underlying medical condition. Start with the veno-venous ECMO configuration or VV ECMO. It is primarily utilized for the respiratory function support where cardiac function remains intact but the pulmonary function is compromised. In this configuration, the cannula facilitates the extraction of deoxygenated blood from the venous system, which is then reoxygenated external before being returned to the venous circulation. Specifically, the blood is typically withdrawn from the central vein, such as the internal jugular, which connect directly to the superior vena cava, ensuring a smooth flow of blood from the upper body region. The oxygenated blood is returned via a different venous pathway, commonly to the cannula placed in the femoral vein. An alternative method utilize a dual lumen cannula, often referred to the dual lumen jugular cannula, which allow both withdrawal and return of the blood to a single site in the jugular vein, optimizing the efficiency of the blood circuit and minimizing potential complications associated with the multiple cannula sites. And next, we will go to explore the veno-arterial ECMO, or the VA configuration, which is utilized to both cardiac and respiratory support. The VA ECMO is critical when both heart and lung are unable to sustain its function, that the arrangement of blood is withdrawn from the venous source, such as jugular vein, similar to the VV setup. However, after the oxygenated process is finished, the blood is returned not to the venous system, but instead is infused into the arterial site. Typically, the femoral artery, this approach allows the oxygenated blood direct delivery into the arterial system efficiently and bypass both heart and lung function, which is crucial in scenarios with heart pumping capable is severely compromised. This arterial infusion helps maintain the perfusion pressure to critical organ despite cardiac insufficiency. To sum up, the steady placement of cannula in both ECMO configuration is vital for ensuring the efficiency of extracorporeal supporting, minimize the mechanical complication, and optimize oxygen delivery and carbon dioxide removal. And this is our reference. Thank you again for your attention. Goodbye.